Good afternoon, everyone. Thank you very much for joining today's webinar on post-traumatic stress syndrome with Vietnam veterans. This webinar today will be recorded online and available to all partners to review next week. Just an FYI, if you have any questions throughout the webinar, please feel free to use the chat box function in Zoom. Please do not use the Q&A section or the raise your hand. Remember to reply all to all panelists and all attendees. Oh, by the way, my name is Emily Marsh. I'm the Leona Veterans Services Associate here, along with Catherine Kemp, who's here as well.
Hi, everyone.
All right, so again, this is a pre-recorded webinar. So if you have any questions about volume, just raise your hand in the chat box and we'll get to you shortly. Thank you very much. Let's get started.
Kind of wound down a little bit, so I'm going to go ahead and close.
All right, before we get started, we're going to start a few polls for you guys to fill out for us. So we're going to launch, there's 3 questions we want you to know. So the first question is, how confident do you feel in assessing the PTSD in veterans? Second question is, how confident do you feel managing symptoms of PTSD in veterans? And how do you feel assessing mental health resources or referrals beyond the capacity of a community hospice? So I'm launching the poll right now. All right, so we're closing the poll right now. All right. So thank you very much. So like the first question.
Share.
So this is the results from the poll. A lot of people said somewhat confident in assessing PTSD symptoms, somewhat confident in managing, and somewhat is a very popular result. So we're going to stop sharing, and now we're going to start the webinar.
For the sake of time, Dr. Sager and I have a limited time for today's presentation, so we do want to note that additional details are available within the notes section of the attached PowerPoint presentation. We also have included a summary presentation handout that is also available for your use as well too. So let's begin. The majority of hospice care for veterans is delivered by community hospice programs in the veteran's home, with most living in rural areas. Public Law 115-141 directed VA to undertake a study on the feasibility of implementing hospice care protocols tailored to the unique needs of combat veterans, including Vietnam-era veterans, and to develop a report outlining the techniques, best practices, and support mechanisms to serve the veterans. This presentation is one of 3 presentations designed to empower community hospices to better equip providers with the tools needed to provide patient-centered end-of-life care to the veterans they serve. I'd like to acknowledge our PTSD and end-of-life work group members noted on the slide as well too. This was an extremely dedicated and passionate team who worked very hard together to put this together for us today, and I thank each one of them. After taking this presentation, participants will be able to identify signs of post-traumatic stress disorder, explain how trauma may impact veterans at end of life, discuss treatment options for PTSD specific to the end of life, understand the similarities and differences between PTSD and other conditions, and know how to best care for Vietnam veterans with PTSD at end of life. Before we begin, as I mentioned earlier, I wanted us to take a few moments to think about and share your experiences about caring for individuals with PTSD or symptoms of PTSD at end of life. And hopefully I can see that that's occurring in the chat box, and I continue to encourage you to write about those experiences throughout the presentation. Early in my career, I had the privilege of working with a Vietnam veteran with PTSD and comorbid substance dependence. And I worked with this veteran over the course of several years, both as an inpatient and outpatient, until he passed under the care of our palliative care team. His life journey had a powerful influence on my professional career, and as a result, it's an honor to have been a part of this work group. I'm sure each of you have stories similar to how the veterans we served have impacted our lives. Let's begin with providing an overview on what is PTSD. PTSD is a disorder resulting from exposure to an actual or threatened death, serious injury, or sexual violence, which results in a significant impairment in functioning. Possible types of traumatic events might include combat trauma, sexual and/or physical abuse or assault, terrorist attack, serious accident, natural disaster. Stress reactions following a traumatic event commonly occur. If they impair functioning, such as work and family relationships, and last longer than 1 month, this might be an indication of the presence of PTSD. In order to meet a criteria for a diagnosis of PTSD, an individual needs to meet 2 criteria. Criterion A involves, as I mentioned, having been part of a traumatic event in some manner. PTSD can result from directly experiencing a traumatic event, witnessing in person an event that happened to someone else, learning about the violent or unexpected death of a family or friend, experiencing repeated or extreme exposure to aversive details of traumatic events. It is important to note that for some veterans who have experienced combat in addition to other types of traumatic events, they may not identify combat as being the most distressing traumatic event they have experienced. This is why it's important to assess for all types of potential traumas over the course of a veteran's life, and not assume that their combat experience is the primary source of their PTSD symptoms. In addition to the type of trauma experienced, a diagnosis of PTSD requires a combination of symptoms from specific symptom clusters that include intrusion or re-experiencing, avoidance, negative alterations in cognition or mood, and hyperarousal. These symptoms must be present for more than 1 month and must cause significant distress or impairment. Additional examples of these cluster symptoms can be found in the notes section. It's also important to note that most people do not develop PTSD symptoms following a trauma. And we also know that the prevalence of PTSD varies across different groups. So the number of veterans with PTSD varies across service eras. Specific to the Vietnam veterans, about 15% were diagnosed with PTSD at the time of the National Vietnam Veterans Readjustment Study. It is estimated that about 30% of Vietnam veterans have experienced PTSD in their lifetime. Other prevalence issues important noting is to be aware that our population is aging rapidly. Again, specific to our Vietnam veterans, they are now all reaching 65 years of age. We also know that subclinical symptoms of PTSD are high among older adults. This means that a veteran might not meet full diagnostic criteria for PTSD, but their symptoms of PTSD could still be causing significant distress and impacting their quality of their lives. We also know that there are higher rates of PTSD when trauma is experienced later in life as well too. And unfortunately, when it comes to end-of-life care, we know that PTSD or symptoms of PTSD do not often present themselves in a typical manner at end of life. There is often misdiagnosis of PTSD with other medical or psychiatric problems. And to further complicate the assessment process, PTSD symptoms are often underreported by older adults. And as was mentioned in the previous slide, subclinical levels are just as important to identify. So it's very important to be attuned to symptoms that are consistent with PTSD. Comorbid physical and mental health disorders are incredibly high among individuals who meet criteria for PTSD. About 80% of individuals with PTSD also have other mental health diagnoses. People with PTSD have an increased risk of depression, anxiety, substance use disorders, and suicidal ideation and intent. The increased risk for suicide among veterans with PTSD is why we have a separate module specific to that topic as a part of this initiative. For our older veterans, PTSD also increases risk for cognitive impairment. There also appear to be some differences in PTSD symptom expression between younger and older. Weakness and estrangement from others may increase with age. Survivor guilt and dissociation may actually decline with age. Older versus younger veterans with PTSD may report more somatic complaints, so difficulty with sleep, appetite, or identify memory problems, and fewer symptoms of arousal, numbing, depression, hostility, and guilt. And after exposure in late life, older adults, based on data from veterans who served during World War II in Korea, they tend to show more hyperarousal, preoccupation, avoidance, sleep disturbance, crying spells, and less re-experiencing symptoms than middle-aged older adults. So symptom expression may vary over the course of the lifetime. In the next few slides, we're going to provide an overview on the way PTSD symptoms can impact end-of-life care and introduce the trauma-informed care approach as a way to address care needs. Living with a life-threatening illness may provoke similar responses to the original trauma and increase distress and symptoms of PTSD at end of life. If you are, for example, we know that there may be a sense of loss of control and need for reliance on others, an increased sense of fear when we're dealing with a life-limiting illness. Normal life review, which is a common process when living with a life-limiting illness, may result in symptoms such as intense anxiety, anger, guilt, or sadness due to traumatic memories or the response that the symptoms had on the individual's life course. For example, to help resolve feelings of guilt, a veteran might feel the need to apologize to his family for the way the trauma and resulting symptoms of PTSD had impacted their life as a family before he passed. Avoidance symptoms, which are characteristic of PTSD, may interfere with medical care and at times could lead to poor medical adherence and impede the ability for providers to engage in direct problem-focused communication regarding care needs. This can extend into nursing and personal care activities. PTSD negatively interferes with relationships with family and friends. Individuals who have PTSD may experience decreased social support as a lack of caregivers as a result of social isolation and avoidance. As a result, they might need more frequent visits or check-ins from hospice providers due to that limited social support. A point of interest is that medication management for pain for some veterans can actually increase PTSD symptoms. There is a very informative NPR piece listed on the slide that illustrates the potential reaction to medication from a veteran's perspective, which I encourage everyone to go online and listen to or read the transcript. When the intersection of end-of-life concerns and PTSD are examined, it's no surprise why PTSD complicates end-of-life concerns further. To illustrate this point, we can simply look at some of the end-of-life concerns and see how they directly conflict with potential PTSD symptoms. So as I mentioned already, toward the end of life, there is an increased reliance on family and social support. PTSD symptoms can lead folks to become isolated and detached from others. At end of life, there's importance of life review and resolving unfinished business. At the same time, these can be triggers for trauma memories that individuals with PTSD might prefer to avoid. With the complexities that PTSD can add to the end-of-life care, it's important for hospice providers to utilize a trauma-informed care approach. A trauma-informed program realizes the widespread impact of trauma and understands the potential paths for recovery, recognizes the signs and symptoms of trauma, responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. This approach provides a framework to provide patient-centered care. Let's learn how to recognize the signs and symptoms of trauma. We're going to review 4 components of assessment of PTSD at end of life. Gathering a solid medical history, particularly if there are limited medical records, is essential to determine if there's a need to incorporate trauma-related treatment into the hospice care plan. After reviewing any medical records, it's important to gather some information about the individual's military history, and if they are a veteran, gather information specific to their life experiences. A useful tool called the Military History Checklist, available on the WeHonorVeterans.org website, is a wonderful tool to utilize within your hospice practice. It is important to remember, even if a veteran has experienced combat or another traumatic event, that it does not mean that they have PTSD. This information simply serves as a piece of data that increases risk to having PTSD symptoms at end of life, even if they do not meet full criteria. Just some other examples of predisposing risk factors or events include earlier depression or anxiety impacting brain chemistry, poor coping skills, having experienced multiple losses as examples. Information from collateral reports also can help to identify PTSD. For example, a family member might share that they never talk about what happened during their service in Vietnam, or that they sleep in separate rooms from their spouse due to veterans' concern that they might hurt their partner if they are startled during sleep. PTSD symptoms may be triggered or cued by a variety of situations in care settings, depending upon the nature of the traumatic event. It's important for all care providers and family members to use their observation skills to look for warning signs of PTSD that might complicate end-of-life concerns. The most effective way to screen for PTSD is to ask about current symptoms and past traumas. The primary care PTSD screen is a 5-item self-report screen used in primary care settings. A score is positive if there's 3 or more yes responses. The 5 questions on the screen include, have you ever had an experience that was so frightening, horrible, or upsetting that in the past month you have had nightmares about it or thought about it when you did not want to? Tried hard not to think about it or went out of your way to avoid situations that reminded you of it? Were constantly on guard, watchful, or easily startled? Felt numb or detached from others, activities, or your surroundings? And lastly, felt guilty or unable to stop blaming yourself or others for the events or any problems the events may have caused. treatment options for PTSD in late life include psychoeducation, psychotherapy, and pharmacotherapy. In regards to psychotherapy options, this section will highlight evidence to the literature for the effectiveness of various approaches, challenges with traditional recommended treatments, adaptations, and approaches to use in hospice care settings. Regardless of the treatment used, psychoeducation is recommended to help patients as well as their families understand PTSD and how it may be triggered or worsened at the end of life. Psychotherapy and pharmacotherapy have both been found to be effective in treating PTSD. Clinical practice guidelines now recommend individual, manualized, trauma-focused psychotherapy such as prolonged exposure, cognitive processing therapy, or eye movement desensitization reprocessing over other pharmacological and non-pharmacological interventions for the primary treatment of PTSD. These treatments have the best evidence in the general population. Although the literature is clear on which treatment approaches are most effective in treating PTSD, there are many challenges with recommended treatments specific to hospice settings. These are some examples. I think I would highlight the requirement of too much patient stamina, the amount of time that these take, multiple visits for upwards of 20 sessions from 60 to 90 minutes at a time. There are other examples up there as well. In addition, little research has studied these recommended treatments in older individuals, particularly those 85 or older, and almost none with individuals at end of life. There have been some studies on modifications or alternative approaches that have been used in working with this population, but they are limited. Treatment of PTSD in hospice care is determined by three things: life expectancy, acuity and nature of symptoms, and anticipated drug side effects. There was a recent review article in the American Journal of Hospice and Palliative Medicine on the assessment and treatment considerations of PTSD at end of life, which is an incredibly useful resource and provides a tailored overview on adaptations and approaches to address PTSD in hospice settings. When discussing the ways in which PTSD symptoms can complicate end-of-life issues, earlier, the trauma-informed care approach was introduced. These are some examples of the elements of trauma-informed care that can be used in hospice settings. We are going to use a case-based approach to illustrate how to modify approaches to provide trauma-informed care within hospice care. So let's go ahead and start with a very straightforward case, but it'll be useful to illustrate this adapted approach. A hospice nurse went to complete the initial intake with a veteran referred for home hospice. Upon arriving, his wife shared with the nurse that he has battled chronic PTSD since returning from Vietnam and has difficulty trusting other people. So for a useful approach to address PTSD in hospice care is the stepwise psychosocial stage model for treating PTSD at end of life, a patient-centered approach. There are 3 stages to this model, and treatment only moves on to the next stage if symptoms are not resolved and if the veteran would like additional treatment. So let's look at this case from the first stage. Stage 1 of the model aims to palliate immediate discomfort, provide social support, and psychoeducation. Stage 1 targets what can be done in terms of the environment, relationships, and interventions, all designed to facilitate comfort. Referring back to the case in the previous slide, let's consider what stage 1 techniques would help facilitate rapport with the veteran illustrated in the case. So, for example, in terms of the environment, hospice team would want to help facilitate a relaxed environment that could be done with thoughtful of scheduling of providers, not having an influx of providers in a short period of time, engaging in relational techniques such as asking instead of tell, explaining the purpose of the visit and procedures, remaining accountable, These things would all help build trust. Incorporating interventions into the care plan that provide psychoeducation and avoid triggering of symptoms are other ways to address care needs. Part 2. As the hospice care team worked with the veteran, he began having significant difficulty with increased anxiety upon wakening early in the morning and finding himself alone. He had previously completed trauma treatment. The licensed clinical social worker was able to review coping skills he had previously learned during treatment and found helpful. He successfully incorporated relaxation and breathing exercises into his routine. His family was alerted to increased frequency checks to provide additional reassurance and comfort if they found him awake. So these are some examples that can be used during stage 2 of this model. Part 3. As his health declines, his symptoms appear to be worsening. He would like to engage in psychotherapy, and at this point in his disease progression, he is able to participate in individual sessions, but he would prefer to use telehealth. Now, I want to stop here and just note that it's been in my experience working in hospice care that many symptoms of PTSD are successfully managed using the techniques from the first 2 stages. If the veteran desires further intervention, this is the point in the model that the hospice agency would refer to another provider trained in evidence-based treatments for PTSD if they do not have a provider that has those certifications on staff. These are some examples of stage 3 techniques that providers might use on the slide. We wanted to be sure that you had some resources available to you on how to access additional consultation and support. So this is the resource information for the PTSD consultation program, which is available to any provider within and outside the VA. So this would be something that a hospice agency could utilize if they had a veteran that they were concerned about, or any individual with PTSD. The next couple slides focus on the goals of telehealth. As was illustrated in the case, the veteran desired individual sessions, but because of his health status, he needed to and preferred the telehealth option. So we have a number of telehealth objectives related to this initiative that are listed here on the slide. And this next slide provides hospice agencies with ways to access telemental health services. So if a hospice agency needed to facilitate access to telemental health for veterans, these are the resources that they could use to help meet that need. Now we are going to discuss pharmacological approaches to care, and I'm going to pass it over to Dr. Sager.
Great. Thank you, Kristen. That was wonderful. So, as Kristen said, we're going to talk a bit about some of the medication-based approaches for targeting PTSD symptoms. And then we're going to go on and talk about some things that also might look like PTSD at end of life. And I think it's important to stress that medications alone are not going to be enough to treat PTSD. PTSD is not an illness that if you give them a pill, it will suddenly go away. That really the best evidence exists for these psychotherapeutic approaches to treatment. And I think it really starts with, like Kristen said, is you're building on trust, you're forming a really strong therapeutic alliance with these patients, and you're really working on just to provide a lot of psychoeducation about how to address symptoms, helping them understand what they might be experiencing. But when those things aren't enough, we often consider would a medication be effective. There are 2 medications that are FDA approved for PTSD, that's sertraline and paroxetine, who are listed here. And then based on the American Psychological Association's clinical practice guidelines, there are other medications that also have a good body of evidence to support their use, and that includes fluoxetine, That's another SSRI. It's in the same class of sertraline and paroxetine. And then venlafaxine, which is an SNRI. You'll notice that there's a relatively short list of medications that have good evidence for use in PTSD, and here you see a much longer list of evidence that are a much longer list of medications that are things to avoid specifically in PTSD treatment. And this is based on the data that we have from the VA and the Department of Defense, their own clinical practice guidelines that suggest against the use of these medications for treatment of PTSD as monotherapy. And that's either because there's not a whole lot of evidence that they actually work, or they have a bad side effect profile, or they cause adverse effects. And I think as you look through this list as a hospice provider, the first thing that comes to mind is these are a lot of the medications that I wind up using on a day-to-day basis in my work. And so this first bulletin here, it's got the list of second-generation antipsychotics, olanzapine, quetiapine, and risperidol. Citalopram is another SSRI. Amitriptyline, commonly used for sleep, is a TCA. Lamotrigine and topiramate, which are mood stabilizers. Benzodiazepines, which frequently get used in end of life. Prazosin is often used for nightmares. And then in the community, we're seeing more and more individuals who are pursuing cannabis on hospice and other situations. And currently we think that these have evidence that they're not the best treatment options. And so as a hospice provider, you really have to weigh the risks and benefits of these particular treatments. I don't want people to walk away from this and feel like, gosh, now I should never use Haldol or never use Ativan. But I'm hoping that people will think much more critically about the medications that they're using, the symptoms that they're trying to treat, and that if something's not working, to make sure that instead of the medication just hanging on, that it's removed. But I can't stress enough, like the first time that I saw that list, is like, gosh, these are a lot of the medications that I wind up using when I'm seeing a patient on home hospice. And so some of the things that you're considering when pursuing pharmacotherapy for a veteran or anyone with PTSD at end of life is that a lot of the PTSD symptoms can mirror common end of life symptoms. So on the right-hand side, people wrote in some things and they said paranoia or hallucinations. In someone who's not able to really communicate, it'd be really difficult to tell if someone had, symptoms from PTSD or if that was terminal delirium. And so that would be an instance where a short trial of an antipsychotic might be indicated to see if it responded, and maybe that would give some indication that it was terminal delirium. But if it didn't respond, then it would be an instance where I would take away that medication and be thinking, gosh, this could possibly be some reemergence of PTSD symptoms. What are my other approaches? Anytime I'm thinking about starting a medication at the end of life, I'm really thinking first about what is this individual's prognosis. So the medications that we list, the sertraline, paroxetine, fluoxetine, and venlafaxine, those are all medications that take several weeks to several months, about 1 to 2 months to be effective. So for a veteran who has a limited prognosis on hospice that might only be alive for a week or two, it wouldn't make sense to start a medication. It wouldn't make sense to start that type of medication. And also, you have to be aware of, what is the swallowing ability of the patient as their disease progresses. And as the illness progresses, how are you going to manage tapering? So some of those medications that we listed before, particularly paroxetine and venlafaxine, are kind of notorious for having a bad withdrawal effect. And so those would be medications, or if I saw a veteran who, they might benefit from being on the medication for PTSD, look like they had several months that they were going to live, they could swallow right now, I would think more about starting them on something like sertraline or fluoxetine, then paroxetine or venlafaxine, just because I would worry that, gosh, if they lost the ability to swallow or if their situation changed suddenly, what would I do in being able to taper them solely off those medications? And another consideration is that, in hospice, we're really thinking about the family as a unit of care. And there's often times in my work where I've seen a veteran on hospice who there's a lot of distress from the veteran, and it's causing a really significant amount of distress in the family. And, those are instances where you use more medications to pursue, possibly more sedation, because you recognize that really what you're managing right now is the family's distress, and you're helping the narrative for the family moving ahead. And then I think it's important to just stress again that, medications are not enough for veterans with PTSD, that a lot of psychoeducation needs to happen about kind of what PTSD looks like. Some of the other issues that show up at the end of life that can look really similar to PTSD, and we'll kind of walk through those here. The first one is later adulthood trauma re-engagement, which we'll talk about. And then moral injury, we'll spend just a moment talking about that because I know you guys have another hour webinar coming up. And then some of the comorbid factors that go along with PTSD and how it can affect, the team and also individuals around the veteran. So what is later adulthood trauma re-engagement? This is probably a new term for many folks, and it's this phenomenon that we see in veterans. And what we see is that for veterans who are exposed to combat, as they get older and as they're going through the process of meaning-making and reflecting on their life, that they'll often re-engage with these memories of war. And that re-engagement, and it often coincides with like a tumultuous life event, so it can happen after a new illness diagnosis, the death of a spouse, maybe a move or retirement, but something will kind of trigger the individual to start re-engaging with these older memories. And this can be an opportunity. So some people will re-engage with these old memories and be able to make sense and have a sense of growth and meaning from them. But they can also be a sense of distress. I just had a veteran this morning who I saw in my palliative care clinic who had a return of a cancer diagnosis that he thought he had beat. And along with this, he started to think much more about his service in Vietnam. And this also led to him drinking more frequently. And so we really started to talk about this phenomenon of later adulthood trauma re-engagement. So one of the big ways that you differentiate later from PTSD is that in PTSD, one of the prominent symptoms, especially in older adults, is avoidance. But in later, you find that veterans are actively re-engaging with these older traumatic memories. So that's one of the helpful ways of differentiating them. And it's possible that someone can have some of the signs of later adulthood trauma re-engagement and also have a diagnosis of PTSD, so they're not mutually exclusive. But I think the big thing here is that for veterans who are looking back on these periods of their life, it's really an opportunity for us to help them make meaning from this experience. Moral injury, we have one of the definitions up here from Prevalence, is that second quote here, and he's at the Boston VA, and he's done a lot of work on moral injury. And broadly, when we think about moral injury, we think about an individual who has been exposed to an event or done something that kind of violates these core moral or ethical beliefs that they have. And so, this is an individual who was in a wartime situation and was faced with, having to kill someone, possibly a civilian, because they felt like their life was at risk. And it was the thing that they had to do in that moment, but that reflecting on it, it can cause a significant amount of distress. And moral injury is different for different people based on their own religious or spiritual beliefs, their culture that they were raised in, the organization, and also it can kind of change with the time. And so the way that we viewed something 30, 40, 50 years ago might be different than how we view it now. And these symptoms of moral injury can sometimes overlap with PTSD. And so it can be hard at times to figure out, I see this veteran who's distressed, but I'm not sure, is this moral injury? Is it PTSD? Is it later adulthood trauma re-engagement? And sometimes it can take a lot of time. It can be kind of difficult to parse all these things apart. So, you can see on this graphic here some of the, differences between PTSD and moral injury. I'm going to kind of highlight some of the things in the middle that I think are really important, is that, often one of the first things before we find out that someone has a PTSD that we often see in hospice someone with a substance use disorder, and commonly that's alcohol use disorder. And so, substance use is a clue to me that there's likely an underlying trauma. Sleep issues, that could be a possible way to discuss trauma with a veteran. And then some of these negative cognitions, and these are really common. And so someone who has guilt over what they've done or experienced shame over periods of their life, feel like they betrayed their friends or family or even themselves. These are things that can lend themselves towards PTSD or moral injury. And then you see some of the trust issues, and that was one of the things that was brought up in the chat on the right that commonly shows up. And this is why I think it's super important as hospice providers to kind of build that therapeutic alliance. Coming onto hospice is hard. It often means a loss of a previous care team. And anytime there's a transition in care, it can be really frightening for just about anybody, but especially if you have PTSD and have existing problems trusting providers. These are some other ways in which moral injury can show up in veterans. Sometimes over the process of a life review, that'll start to reopen some older wounds that they had buried for many years. And that doesn't mean that you should go right back to burying them, but if the veteran can tolerate some careful discussion about it, then it can be really meaningful. Sometimes you'll hear from veterans that they feel like they're unable to forgive themselves, and almost like there's this kind of fatalistic sense that they deserve what they're going through. And that kind of leads into this kind of worry or fear that they're not worthy of redemption or they're worthy of the care that they're receiving from the hospice. Again, we've talked a couple times about trust, and that's something that comes up frequently. And then you can also see an individual who just expresses despair, that they had, lost the meaning in their life, or they felt like the things that they did didn't have purpose. And so, to close, we have a couple of slides that I want to walk through, and the first one we'll talk about kind of how to talk about trauma with veterans. We will talk about how PTSD impacts those in the family unit. And then finally, I think it's important to close with, as we engage with veterans and as we engage with just anyone with a history of trauma, how do we take care of ourselves? And so first, I think it's important to highlight some of the missteps in working with veterans. And I suspect that this is probably reviewed for most folks here, but just some things not to do. I just had a veteran this morning who told me that it's the same veteran who described some of these later adulthood trauma re-engagement symptoms, that one of the things that had really been bothering him is that someone had thanked him for his service and told him that they kind of understood what he had been through. And he had this kind of feeling inside that this is not someone who knows what I've been through. And so I think it's really important, as providers, we really want to help people and make sure that they feel heard and supported, and sometimes it's really tough. We don't know what to say. And I think this is an instance where just therapeutic silence, just, you're offering your presence is really important, but really getting away from saying like, I know what you've been through, or I can understand, unless you were right there with them. Certainly don't ask people if they've seen someone if they've killed someone themselves or saw someone killed. There can be other ways to talk about traumatic memories. And this first point, making assumptions about someone's military experience. The experience of veterans is an incredibly wide experience, and that veterans often, even though they have a veteran, even though they serve, they don't identify fully as just a veteran. There's multiple parts to their personality and multiple parts to kind of who they are. And certainly not trying to impose your own values on an individual. This slide talks a bit about how PTSD impacts the family. And what we see in individuals with PTSD is that frequently there's more marital problems, there's higher rates of domestic violence in families with PTSD. The partners similarly have more distress, and the children can also develop behavior problems. And this makes sense if you're looking at it through an attachment lens or family system lens, that if you have a parent who, growing up, is suffering from PTSD, maybe is feeling more irritable, is shut down part of the time, that's going to impact how the children interact with that parent. And those things are going to continue over the course of their lifetime. There's just a great article that just came out in the most recent Journal of the American Geriatric Society talking about older adults who had a past year diagnosis of substance use disorders or psychiatric illness. And it looked at the rates of adverse childhood experiences of these older adults. And what they saw was that about 20% of those individuals, 20% of these individuals with a past year psychiatric diagnosis reported having a parent in the home with a psychiatric illness. And that's important for a couple of reasons. It's important because there's certain psychiatric illnesses that have a genetic component and are passed down. But what I took away from that is that there's an attachment component, and that as the person was growing up, they weren't able to fully have their parents present. And so I think that we really see this impact of PTSD throughout the lifespan, and it's not going to stop just when an individual is on hospice. I want to close with just how important it is when we're thinking about self-care for providers. Hospice work is hard work. Kind of addressing PTSD either as a nurse, as a therapist, as a physician is really difficult. And then I know that, as a palliative care provider myself, I go to work every day with the goal of reducing suffering. And I also know that there is an endless supply of suffering in the world. And I can easily exhaust myself trying to, kind of fix everybody's suffering or being present for everyone. And it's really important, especially working with people who have had traumatic experiences, to recognize that everyone has their limits. And there's going to be times when I need a peer who's to support me through the work, or I need to go and do a home visit with someone else just because it's hard for me to do alone. And I want to encourage everyone that it's okay to do those things, and it's part of being a good therapist. It's part of being a good nurse and a good clinician is being able to ask for help. And these things make us better. And we can't do this work if we don't take care of ourselves. So really being thoughtful of what is your own self-care plan? What are the things that you need to do to take care of yourself to be able to sustain this work? To close, we have some resources here, but I'm really excited to kind of hear from the audience, and Kristen and I can take questions. And so we'll leave this resource slide up, but thanks everyone for listening.
Before we get started with the question and answers, maybe we should put up the polling question.
Oh, yeah.
Hello, everyone. So we're going to do another poll. And the poll is launching now. Thank you for your participation. Thank you, everyone. We're going to end the poll right now, and we're going to check results.
Nice. It looks like there's a lot less somewhat, a lot more confident in our participants, so happy to see that.
Well, thank you everyone for attending the poll. So we're going to open it up to a Q&A.
Yeah, I want to just take a minute to introduce Dr. Zachary Sager and Kristen Sirocco. So they are actually with the Department of Veterans Affairs. They are subject matter experts in PTSD and part of the work group. Zach and Kristen, if you wouldn't mind maybe speaking a little bit about the work that you do and how you became involved in the work group.
Kristen, you want to go first?
Sure, that's totally fine. Good afternoon, everyone. Thank you for joining us today. I have been involved in palliative care for over a decade now. I was part of a team who implemented our inpatient palliative care consult team here at the Oklahoma City VA, and then worked to establish our outpatient palliative care services, where I've been serving as a provider now for several years. I've tried to get involved as much as I can on a national level to help improve the mental health care for our older veterans at end of life. And through some of the work I've done, I've just had the good fortune of being connected with a great group of people who allowed me to be a part of this work group. You're up, Zach.
Okay. It was good. I'm glad you went first because I couldn't remember how I got into the work group. So I trained as a psychiatrist and then did a palliative care fellowship. And I think in medical school, I kind of knew I wanted to take care of folks at the end of life. And early in residency, really started to see the world kind of through this lens of trauma. And so the kind of natural thing for me was to kind of think about, well, what's the impact of trauma at the end of life and how does it show up? And then in my fellowship, I kind of saw that, we don't know much about this. And there's not, it was hard to find information on it. It's hard to find interventions. So that kind of led me to pursuing a research path to spend more time investigating this and working to come up to better understand the problem and also to come up with interventions. And it's through that work and my mentor that I got connected to the work group and creating this and connected with Kristen. So, and here we are.
And here we are, yes, and thank you both again so much for joining us. First question, just to kind of kick things off. So one attendee is asking, why do you call PTS a disorder?
So I think part of that is because of the DSM and because the people who came up with the nomenclature needed a way to, this might be somewhat cynical, but you have to kind of, if you're in a biomedical model, things have to be pathology. And so if it's pathology and you're naming something, it is an illness or a disorder. I'm wondering if the subtext, like kind of underneath that question is that trauma is a really common experience, but not everyone experiences this reaction to trauma. And so at the end of life, I'm less focused on this experience or symptoms related to trauma as a disorder, because I don't necessarily think that thinking in terms of clear DSM criteria is meaningful to people at the end of life, and I'm really trying to work towards healing and giving people validation and space for these experiences. So I'm not so worried about the word disorder at the end. Kristen, I wonder if you have a different response or agree.
No, actually, I completely agree there. I think that the only reason really is because of the diagnostic criteria, but my practice is the same way. It's really about the symptoms that are distressing to the veteran and how can we improve their quality of life. And so it's more so on addressing the symptoms themselves rather than the disorder.
we saw, like, before the diagnosis of PTSD, there was shell shock, and Judith Herman wrote a wonderful book in the 90s called Trauma and Recovery, and in that book she talks about the experience of women in the turn of the 20th century and them experiencing hysteria, and hysteria was often brought on after these women were experiencing sexual trauma. So I think going back through time, it's been called different things, and the name changes over time. And so this is kind of what we've been stuck with since 1980.
Well, good. Thank you for that. All right, next question. Let's see. So how do Vietnam veterans with PTSD differ from other wars in relation to causes, effects, and how that manifests?
So I think that this is, to answer that question, it's important to understand the context of the time in which they served and the culture around their military service. So politically, the Vietnam War was very controversial, and I think when they came home, they had a very different experience than other war eras, and I think that's one thing that does play into the development of symptoms as well, I believe. Zach, other things that you want to add to that?
Yeah, so I agree, and I think that Vietnam was a very different war than World War II, and part of it was I have heard some suggestion that part of it is that, and you see this when you see the therapeutic work I do with Vietnam era veterans, they have this experience of, I was in Vietnam, and then 48 hours later, I was back in California, given papers and a bus ticket, and sent out. And so you have this rapid, suddenly you're charged with, I have to, you have a gun in your hand, and you're having to be put in a situation where you might have to kill people, and then 2 days later you're a civilian. And so there's not necessarily a context for making sense of your experiences, and that's because of the modernity of war and how Vietnam was different. We had planes, we had the way that people were taken in and out of the battlefield was different. One thing I think is important is that, during World War II, there was a common sense of who was the enemy, that when people left the battlefield, they left together. They had a long journey back on boats to the United States, and then when they landed in the United States, they decommissioned the ship, and so there was a period of readjusting together and to consolidating these memories and consolidating it as a group, versus the experience in Vietnam was very individualized. People were taken in and out. You were in country and out of country 48 hours, 72 hours later. And so I think that plays a big role in certainly the social context that you were returning to. Yeah.
And I think with that, I don't know how many people on the phone have had the opportunity to be a part of a pinning ceremony or an honor ceremony for veterans at end of life. It's something that we do for all of our veterans here on our palliative care unit. And I think one thing that I do want to highlight is sometimes, even though the majority of time those services are very healing for individuals, it's really important, and their families, it is also important to collaboratively agree to whether or not that's the best thing for them. There have been some veterans where they have not wanted to be thanked for their service in a public way. And so I just feel that I just wanted to highlight that, because sometimes I find that we make an assumption that will be good for a particular individual, and it's really important to have that conversation with them if they've been dealing with symptoms of PTSD.
Yeah, I would absolutely echo that. And sometimes the conversations about the pinning ceremonies will lead to other, stories or things that come up that might be really helpful in coming up with a plan of care. So the fact that someone might not want a pinning ceremony and saying, hey, like I want to make sure that we respect that and we don't want to do something that you don't want to do, but is there something you're worried about, or is there more that you'd like to tell me about your military experience? And some people just see this as a period of their life that was so distinct and different from everything else, and that they were this person that existed outside the military, and it's just not a central core part of who they are. But other times there's certainly that the military service was traumatic or damaging to them, or they might not wanted to have been there. I mean, these are also Vietnam-era veterans, or folks who might not have had a choice. And we know that the people who didn't have a choice came from lower socioeconomic groups, during the draft. So that that could be part of it as well. So asking is really important. I think that's the big takeaway from working with people with trauma is just always asking, not assuming, is a core part of it.
Thank you both. All right, next question. Very vulnerable time to open a Pandora's box at end of life, meaning if there's not enough time for proper healing, are we sure that we even want to encourage the box to be opened?
So that was actually one of the chat questions I responded to a little bit, and I think you always walk that journey with the veteran wherever they are at, and if symptoms are unresolved and they need to continue to go further and they are in a safe environment with the evidence-based care that they need, then we walk that journey with them. But that's where we go back to the idea of it's really about managing symptoms at that point. What's the least intensive intervention that we can do to maximize the decrease in symptoms?
And I think sometimes when this comes up, when I think about it in my palliative care role, or even in my role I'm seeing folks for therapy, is it my hesitation to ask the question because I'm worried about it, or is it me picking up on what the patient is experiencing? So I think there's two different things. So it's my hesitation, or maybe the patient's hesitation. Sometimes those are hard to parse apart. So I think part of it is knowing am I in a place where I can receive what might be said, or maybe I have reserves about going there, but the patient might not. So I think, again, you can ask questions, you can be curious. If you get the sense that it's causing distress, you can back off. I mean, having done a lot of trauma work with patients, you don't just, if someone's saying they don't want to talk about it, you don't just keep pushing. And you know when to say no, you know when to stop. But I'm also people that have, this is also folks that have had early life trauma, and we're seeing them typically much later in life. So these are, I think the other part to remember is that these are often very, very resilient people, and they can handle a lot. And so I don't want to disempower them to say, well, we can't talk about it because I'm worried about opening something and not being able to pack it up. I mean, it's never that simple, and sometimes you open things up and you get more than you expected, but you just also at times just have to kind of roll with that. So there's no perfect answer, but I think also remembering that these are resilient people, they're here for a reason, they've made it for 50 years past this traumatic event, not because they're weak, but because they're incredibly strong. So I think that's an always important thing to remember, and sometimes a thing to remind the person about too.
And we also never want to underestimate just that power of listening that everybody has the ability to do. There is something so healing about having your story heard and accepted just for what it is, and still being there.
It's a wonderful reminder. So speaking of symptoms, we've had a few people ask again about the NPR episode. So Emma's posted the link, and again, that'll be posted in all of the post-webinar recording materials on the We Honor Veterans website as well. But the question was, with consideration of time constraint for trial and error with meds in weighing benefits versus risks, what is the first recommendation and why for managing PTS symptoms if there is a correlated observation between symptom increase and medication?
If you're getting the sense that symptoms are getting worse, what should be the first thing you reach for? Is that kind of the,
yeah.
That's a, oh man, that's like the $1 million question, right? And I don't know if I have I don't think I have a perfect response. So I think that there's certainly times when there's certainly times in my work where I just don't know. I don't know if it's pain. I can't tell if it's PTSD symptoms that's causing pain, and maybe if I treat the pain, then I will get the PTSD symptoms better. So I fall back on like my knowledge as a palliative care doc and first wanting to reduce the distress that I'm seeing right now. And so if I really think that it's caused, I think if the patient looks physically uncomfortable, I'll often start with a pain medication. And if it doesn't see like that symptoms are improving like after initial doses and maybe like one dose increase, so that you're like over the course of 8 or 12 hours, then I will quickly change tact and think, okay, maybe I'm going to use the approach of using an antipsychotic or pursuing, maybe that's more kind of like agitation or restlessness associated with that. I think the thing I reach for the least is a benzodiazepine, just because I know that it's often causes people to feel less in control, more dissociative, and that can sometimes worsen experiences. So I'm not often reaching for a benzodiazepine. I think when I'm doing this whole thing, I'm also incredibly aware of what I can do in the environment. And so can I make the space as calm as possible? Maybe it's removing certain other people from the situation, or really treating, making sure that the family members aren't distressed when they're coming in the room. And I'm thinking about music, if I'm thinking about touch or sounds. And so that's the other part that's going on. But it is hard for me to say, like, what's the thing that I would reach for first, just because I feel like all these situations are so different. So that's my, like, non-answer. I wish it was easier.
I'd love just to share a quick case that we had related to medication management. So we were with it was a team of us. So it was a palliative care physician, myself as a psychologist, and our social worker, and it was a consult visit, and we were trying to address the pain that this veteran had, and our palliative care physician's go-to was morphine, just because of the just the flexibility of the medicine. And there was an extremely strong reaction from the veteran, because he was also a medic when he was serving in combat. And so that medicine had obviously a lot of meaning attached to it. And so learning how to, kind of, something, we just wanted to address, his pain, and secondarily, he had a reaction that we had to address in session with him. So understanding, what kinds of pain medicines have you had in the past? Do you think about what have been useful for you? Do you know any that you're comfortable trying or don't want to try? I think those types of conversations are also helpful.
Kristen, what did you wind up using? Do you remember?
I think he actually ended up using hydrocodone.
Yeah, that's a really, I mean, it's something I feel like I would not think about that unless I had that experience.
Right, because that is not our go-to for the most part. But again, it was that conversation because that veteran had had some success in the past with that. And so, again, it was what he was comfortable using. And so having that choice and to control to choose on his own was very helpful for him.
I think that's an important reminder is that, like, in hospice, we have a toolkit, and sometimes, like, because of, you know, it's because of financial issues or are there any formulary issues or kind of whatever, sometimes we're limited in what we reach for first. And often we see that, like, you know, morphine works for most people, even if they have renal disease or all sorts of things. And so, but I think that with folks with PTSD or folks that have symptoms of trauma that show up, it's really kind of coming up with an individualized care plan. So in some ways, each time I meet someone, I kind of like scrap everything and start from scratch. And I feel like that some ways when I do that, I don't necessarily walk into a corner that I might have if I would have thought like, oh, this is how I usually do it, and I'm going to take that approach and apply it to the patient versus starting with the patient and working outwards.
All right, next question. So can you please review what signs to look for to note when a person may be disassociating or re-experiencing? What grounding techniques do you use to reorient them to the present at those moments?
Kristen, do you want to start, or do you want me to start?
It doesn't matter.
So some of the ways that you see folks dissociating is maybe they're more confused, or maybe they just like sometimes I'll have this experience of like I'll be in a room with someone and have this feeling of like I don't understand I don't understand why they don't understand. And so it's like I can't understand why I'm not getting through. Or maybe like you show up at the house and things seem kind of disorganized, or like they weren't aware that you were coming, and you're like, well, we were just on the phone, like we just talked about this. So there's like a sense of like something isn't connecting. Sometimes that's an internal notice for me to think like, oh, maybe there's some dissociative symptoms going on. Sometimes people will just look like they're blank, and will zone off while you're talking to them. That's a clear one. And sometimes you'll get people like with a hyperstartle and are just really bothered by things and seem really jittery or agitated or irritable. That's usually a cue to me. For grounding techniques, I often will remind people, maybe I'll do a little breath work with them. I'll make sure that I come in the room and I kind of come in with a calm presence, and so that, you know, before I go in the room, I'm taking a couple of deep breaths myself, and kind of centering myself, and to make sure that that the patient is not made more distressed by me being hurried because, you know, we're running around or whatever. And then often I'll lead the patient through a couple of breaths. Maybe I will talk them about, like, you know, do a short, like, body scan technique with them. I have some other symptoms, but I have some other things that maybe, Kristen, do you want to share some? Or what
Sure,
you see?
yeah. I think grounding techniques are just such a useful tool because just as breathing's one of them, they're very accessible to us and to everybody. So I think, you know, sometimes even just getting the veteran to, you know, state his name again and where they're located and get them grounded to aspects of their environment around them, including, just commenting on the room and the temperature, and you notice a picture over there. Will you tell me about that picture? What was it like when you were with your family member on that vacation, or whatever the case may be? Getting them to really just be mindful of the present moment is very helpful.
There was one, and I know like the last week's webinar talked about like the anchoring heart technique. So that's something that can be used as well. But I think all these things are kind of based by connecting with like yourself at that moment. And so, picking something that's in the room, or picking your breath, something that is here, that's now, that is focusing you on kind of what's going on. I will say that for some folks, grounding techniques can be challenging because, some people have complicated relationships with their bodies, and so a grounding technique, when you say like, let's get into your body, or like if you have lung cancer and you're having them work with their breathing, that can be a really a challenging thing. So sometimes I'll pick another, another way to kind of ground them. Sometimes, like I remember, like I had one patient in a rocking chair, and the way that I grounded them was I asked permission if I could touch their knees, and I breathed and I kind of rocked them back and forth in the chair, with my in-breath and out-breath going like forward and back in the chair. So they had lung cancer and they couldn't, focusing on their breath was hard, but being in the room and noticing the sensation of going back and forth and my breath was kind of what grounded them. So you have to be kind of creative. But, I think the assumption that, I don't always just assume that like getting into your own body is going to be a good thing.
That's a great example, Zach. I love that one. The other thing as well, too, I think as we continue to move on with, disseminating care practices for this group as well, too, and we continue to do assessment with veterans are going to have had more access to care in the future. And, if they've shared with you that they have had an experience of dissociation, and that's something they struggle with, as part of the assessment process, just gathering that information as well too. Well, what tools have you used during that time? Because they are strong, they are resilient, they have been doing this their whole lives, and so most likely you can get that information potentially on the front end too if they offer it.
This might be a strange recommendation, but I can't remember how long ago, a couple years ago, I got a recording it's available like on Audible, and it's Stephen Levine and Ram Dass, and I think there's one other person who created like one of the first hospice organizations in the United States. And the recording is called Dying into Life, and it's like this 8-hour tape series of just these people talking about meditation and end of life and their stories. And they had an exercise where they, with folks who were at the end of life and or might not be kind of aware of their surroundings, but sitting with the person and matching your breathing with their breath. And so when you're breathing in with them, and when you're breathing out, kind of making an audible sigh. And after I listened to this, I will now like use it with folks who are especially alone and might seem distressed, and just the kind of connecting with people and matching your breath to their breath, I've noticed seems to make a difference of kind of calming people down. It seems like they become less restless, and it doesn't involve any touch, which I think is sometimes touch is fraught. But that was just like this random technique I picked up on a an audiobook. So I think, part of this is like you have to go pretty wide and kind of stretch where you're looking for interventions, just because there's not a whole lot out there.
Well, thanks for sharing that. And yeah, Em actually just shared the name of that, and we can include a link and more information too, and all of the information we send out post-webinar. So again, I know we're kind of winding down on time, but if you have any more questions, please submit them. Anything else you just want to share, issues that you've come across related to psychological trauma or PTSD within your clinical setting, anything that's come up, please share in the chat box. I do see one other question. Does morphine have dissociative effects that may work better than other, I'm going to butcher this, analgesics to separate the mind-body physical pain? Is that why morphine is still the drug of choice for vets with PTSD in the hospice setting?
I think morphine is the drug of choice because it's the cheapest opioid. It's the most readily available. It comes as a liquid, and it's been around the longest, or, it's been studied the most. I don't, there's certainly some differences between opioids. I don't think that there's a difference between how someone like if one is more or less dissociative. I think it's largely related to dose, individual tolerance, and so it's not necessarily opioid specific, but I think as a whole, the class is kind of a depressant. Opioid medications are often a depressant, and so that can kind of contribute to a feeling of being numb or being disconnected. And so for some folks, that could be really helpful if you don't have a lot of time and if someone's experiencing a lot of stress. That might be what you're using. But then also, that could also worsen someone's feeling of a loss of control. If they feel like, gosh, I was feeling this, and then I took this, and I'm not feeling it, and now I'm worried because I'm not feeling it. So you have to be kind of mindful of it. But it's not morphine in itself. The reason we use it is largely because of its availability and its cost.
All right, we're not seeing any other questions. Was there anything else that maybe comes up a lot that hasn't been covered in the Q&A, or anything else that you all want to add?
I think I think of this this is hard. It's hard work, and it requires us to often maybe approach things a little bit differently, and make adjustments to how we normally do care. But that often the results can be really amazing. And I think folks with trauma constantly teach me how resilient people are. And it's challenging at times, but it also really encourages me to be open and kind of value people's individual experiences. So I think overall it's a really rewarding thing. And then I always fall back on the thing of I am an empathic, good person. And if you are an empathic person who can listen, that is the most valuable thing. And that's the first thing that you can do that will help probably more than anything else. If you can listen and you can validate and you can be curious, that will take you 90% of the way.
And just to close, I think the other thing that was a constant topic of conversation in the work group who put this together was that element of self-care for all of us. And I just want to close with that this is important work, and it is very hard, as Dr. Sager said, and we need to be very conscious and deliberate about our own self-care so we can serve these folks to the best of their abilities. So I hope everyone's going to do something for themselves this weekend.
What a great point to wrap things up on. Thank you again, so much again, to both of you, Dr. Zachary Sager and Dr. Kristen Sirocco, for joining us. Again, to all the partners that were able to dial in today, thank you for spending your afternoons with us. Again, these slides, links, all information is going to be up on the We Honor Veterans website recording. I did also want to add, as you all know, we do our annual We Honor Veterans Partner Survey. So each year we send this out in an effort to get some feedback from you all. Not only are we meeting your needs, what else can we provide as far as resources, but we want to hear how we're doing. We want to make sure that from a customer service standpoint, we're doing our jobs and we're able to help you better provide service to your patients. I did want to add that this year, working with the Office of Rural Health, and again, Drs. Sager and Sirocco, we are happy to be including a couple of questions that they want some feedback on. So we really, really appreciate you taking the time to fill out this survey. I know that especially at the end of the year, surveys are kind of coming at you from all points, but it really doesn't take long. Help us help you. From this, resources will be created, again, to better help you serve your patients. So we really appreciate you taking the time to fill that out. Again, we're wishing everyone Happy New Year, wonderful holidays. Take some time for yourselves. We'll be in touch again soon, and we look forward to working with you in 2020 going forward. Thank you all.
Thanks.
Thank you.